Good morning, everyone. So let's talk about aortic trauma. First of all, it's a very rare injury. It's less than 1% of motor vehicle accident, and in autopsy studies, it shows that it's a higher number of injury because it's around 16% of the deaths, and between 58 and 86% of death before hospital admission. So the patient we will see arriving in the hospital will be very rare. It's around 1%. The other one will be dying before arrival. So mechanisms of injury are multiple. It can be direct trauma, here with a pinch in the aorta, and mobilization of the mobile part of the heart in the front and the spine behind that makes lesion on the aortic arch. Then it can be extrinsic mechanism with stretching, for example, and shearing, and intrinsic mechanism, which is called water hammer effect, which is the blood flow coming from the abdominal injury, for example. And when the aortic valve is closing, there is a counterflow that can do injury on the aortic wall around the arch, or based more downstream on the aorta. So the aortic wall is made of 3 layers. There is first the endothelium, but it's intima, media, and adventitia. And the grading of aortic injuries is based on the injuries of these layers. First of all, when you just have an injury of the intima, it's a grade 1 or grade 2, according to the size of the injury. Then when you have an injury of the 2 layers, intima and media, it's grade 2. And you can see here, you can have like a pseudo-aneurysm because the blood is just contained by the adventitia. And when you have the 3 layers, it's aortic rupture that can be contained in the mediastinum, but it's a very, very emergent situation. So we made a retrospective study in the French trauma registry between 2013 and 2018. And we found a series of more than 200 aortic injury. It's blunt trauma aortic injury. We just take the blunt one. We didn't take the penetrating. And we found 1% of admission in trauma center with an average age, a median age of 43, median ISS of 34, which is very high, and a high physiologic score and a mortality around 20%. When we analyze the mechanism leading to this injury, it's 1/3 of car crash, 1/3 of motorbike accident, and 1/3 of falls. So this helps to understand that it's a mechanism with a high velocity. These patients are transported to the hospital, present in shock in around 40% of the cases, or in cardiac arrest in 6% of the cases. And you can see that they have already a low capillary hemoglobin and a red flag score around 2. It's a median of 2. When they arrive in the resuscitation room, they have, for almost half of them, vasopressor, and they arrive with a high systolic arterial pressure, at least a maintained systolic arterial pressure, and we will discuss that later on. They have been bleeding compared to the pre-hospital. It's a lower hemoglobin. 30% of them will be transfused, and 10% of them will be directed transport to the OR for associated injuries. So concerning the properly aortic injuries, it's 50% of grade 1 and 2, so intima injury, and it's 30% of grade 3, and a lower rate of grade 4. And most of the injuries are situated in the isthmus. It's 3/4 of all the injuries. And you can see that the aortic injury is always associated with many injuries. It's never alone, and it's more than 3/4 of the time with thoracic injuries, but you can have spinal, head, abdominal injuries. It's always associated with polytrauma. These patients have a proposition of treatment. We will come back to the treatment, but there are early repair in 60% of the cases. And they stay a median time of 6 days in the ICU. So that's the identity card of patient having blunt traumatic aortic injury. So now, with all of that, we have to anticipate their arrival and know what we are doing when we know that this patient will present or have an aortic injury. So, first of all, in the resuscitation room, we can do FAST and X-ray. In our series, we've done the FAST in 80% of the cases. It was normal in 1 case over 2. And all the findings were very aspecific. So, fast echo won't help us, except if you find a hemopericardium that will orient your diagnosis to the aortic injury. Otherwise, it's very aspecific. Concerning chest X-ray, in our series, it was done in 1 case over 2, and it was normal almost also in 50% of the cases. And the findings were quite aspecific, except the enlargement of mediastinum, which was found only in 17% of the cases, which is very different from American series, shown here. It was published in 2015. They present all the findings in the chest X-ray for the patient presenting with a blunt traumatic aortic injury. And you can see its enlargement of the mediastinum is 85%. And when you find that and you have a disparition of aortic knob, it's very easy to know that your patient is presenting blunt traumatic aortic injury. You can have lowering of the left main bronchus, left hemothorax, which can be specific, but associated with all the lesions, it can help you to be oriented. And sometimes you have these kind of findings which have no suspense. You know what's happening, and I remember this patient. He was 29 years old, and we did the X-ray in the recess, and then we go to the CT scan, and we came back and we saw his family, and he said, his daughter, I promise I send my motorbike. And then when we come back to go to the OR, he just collapsed, and he died because it was a grade 4. So, be helped by FAST or X-ray is quite hard. It can be, but it can help you anticipate because the surgeon will be already measuring the aorta on the CT scan to get ready to operate, and, but it's sometimes too late. But it can help you to anticipate the respect of the guidelines and, for example, the systolic arterial pressure targets, and avoid over-resuscitation, because you will, if you put your systolic arterial pressure too high, you will have constraint on the aortic wall, and you might increase the severity of the lesions. And in our series, we found that down there in the table, for patients with no TBI, the first systolic arterial pressure in the recovery room was 113, and the last one in the recovery room, so a few 20 to 30 minutes later, was 115. And almost half of the patients were under vasopressor. So we can say that in these cases, we had over-resuscitation. In patients presenting severe TBI, it's different. This patient arrived with a low arterial pressure, and they were put under vasopressor to get the blood pressure targets. But at least if you have the idea of this aortic injury, you can be very moderated into your targets. Then, if you put a chest tube, you can be very careful for the hemothorax, especially if it's on the left side. Also, you have to think about preserving femoral access for endograft, and think about not putting a rebar, otherwise your patient will be dead. So the diagnosis will be done in the CT scan. It's a gold standard with a very high sensitivity, specificity. It completely replaced angiography. and it allows the grading of the injuries. So here is a grade 2. You can see here, and here the flap. Here again. Here is a grade 3, and you can see the pseudo-aneurysm. Another one in a reconstruction. And here we had an enlargement of the mediastinum on the X-ray. And the grade 4, so there is aortic rupture, and this patient is still alive. Because it's contained in the mediastinum, and we don't know by which mean of this patient can be still alive with aortic rupture. But in this patient, you don't have to put the pressure higher. So you can also have indirect signs, so aortic parietal hematoma or mediastinal hematoma. But in patients that you drive directly to the OR, how can you make the diagnosis? You can have the diagnosis with transesophageal echocardiography, which is quite good in predictive values. And you can see the intimal flap or the intramural hematoma, or even the aortic rupture with a very large intestinal flap. And you can be guided also with the analysis of the aortic valve. So, what are the therapeutic options? It's open surgery, endograft, endovascular surgery, or non-operative management. In our series, so the patient having an interventional treatment were 142, it's 60% of the patient, and 94% of them had endograft, and only 10% had open surgery. 2 of them have combined surgery, that's why it's more than 100%. 90% of them were operated early, within the first 24 hours. And when we look at the non-operative management and we compare our series here in blue with an American series of the Aortic Trauma Foundation, we can see that mostly it's grade 1 who are driven with medical management and non-operative management. And you can see that in our series, the grade 4 is 43% of non-operative management. Is the analysis of all these patients were patients that were very severe on associated injuries, and especially traumatic brain injuries, so they were not operated, not because there was no indication, but because they were too severe. So the endovascular treatment is now the first-line treatment. Of course, it depends on the localization of the injury. Sometimes it's not possible. It's better than open surgery because the physiological burden is lower. There is no bypass, no heparin, at least not a lot of heparin for a long time, but you can need heparin during the endograft procedure. You don't have to make single lung ventilation. You can be due to put antiplatelets for a few days. And so far, we have a long-term device integrity. So this is the film about the treatment by endograft endovascular surgery. So you deploy the prosthesis in the aorta progressively. You can see here it's the isthmus, so it's in more than 70% of the cases where the injuries is located. And then you deploy progressively the endograft until the end. And the procedure is like 2 hours, it's finished. When you speak about the complication, in our series we had 9% of stroke, 6% of graft migration, 4% of paraplegia, 1% of infection, and less than 1% of arteriovenous fistula. So it's difficult to compare endograft and open surgery in this kind of series because there was very, very few patients with open surgery. But when you compare to international series, you can see that the complications with endograft are far lower. When it comes to mortality, the patient died very early because of hemorrhagic shock in most of the cases. It's 38% of hemorrhagic shock and 31% of physiologic collapse post-hemorrhagic shock. In some cases, it's because of brain trauma. And when we compare with another series of traumatic aortic foundation, their series showed a 12.5% of the cases of death. So, in conclusion, it's a rare injury. It's 1% of the patient arriving in the trauma center, but it's severe because it leads to a mortality of around 20%. It has to be suspected from the pre-hospital setting because of mechanism, high-velocity mechanism. Then it can be suspected on X-ray with some of the signs which also are quite rare. And then it can be diagnosed on transesophageal echocardiography if your patient is driven to the OR before going to the whole-body CT scan. It needs timely intervention, first of all resuscitation, but also interventional management, mostly endograft. But the real good timing for this intervention is still under research because we don't know if it's very necessary to operate this patient very early. And the last series of the Aortic Trauma Foundation is saying it's probably no, because they analyzed the patient with a TBI, and even the patient operated later had the same mortality. And finally, endovascular treatment is the first-line treatment. Thank you for your attention.
Thank you, Sophie, for a very nice overview. Any questions from the audience, or we are monitoring also the online chat for people that are connected? I have a question. It's a curiosity. You showed us the percentage of conservative management in your series for grade 4 due clearly to the severity of the patient. Was there any survivor in that group of patients?
The patient non-operated, grade 4?
Yeah.
No.
Good.
No. In the article, we listed all the cause of death, but there was no.
And moving to that, what about the grade 2 injuries and the gray area where sometimes you find some disagreement between conservative management, operator management, and I've seen different hospitals have different approaches to this. Is there any data that shows differences in outcomes, or does it depend on the volume of what you do and what you're most familiar with?
No, in fact, the series about traumatic aortic injury are very few.
Yeah.
And it's now the Traumatic Aortic Foundation, which are publishing very big series with more than 400 and 800 patients. So now it's becoming very interesting to see what's happening. But all the treatments have changed during this period, so now we need follow-up. In our series, the follow-up was an average of 400 days, which is not so long. Some patients have been followed by five years, but it was not homogeneous. So now we know that grade 1, they are not operated. Grade 2, there is still a discussion, but in this discussion, we do not intervene. It's very surgical and interventional discussion. And sometimes our radiologists, who are the one who put the endograft, sometimes it's also the surgeon, but it depends. They don't agree, but at the end, we don't have the answer in the literature. And listening to their arguments is very interesting because, at least, I would say, I prefer having an endograft than dying of an aortic rupture, but having an endograft and when you don't know what it will be in 40 years is not so comfortable.
Well, I've seen those conversations everywhere.
Yeah. The same.
And is there any role for medical management like beta blockers or other drugs in the conservative approach?
Yes, so in the patient presenting grade 1 and grade 2, for example, that won't be operated, it's a medical management that is targeted to the control of aortic pressure. So to control aortic pressure, you put mostly antihypertensive drugs, and the best one is a beta blocker. So these are well described also in the literature.
And we want the rate below the rate of the patient, the heart rate.
It's not about heart rate, it's more about the blood pressure.
The
blood pressure, we try to trigger, if there is no brain trauma, we try to trigger between 12, 13, no more than 14.
What do you think in a trauma center, it's the best way to diagnose a traumatic aneurysm? Is it should every center has a transesophageal way to do it?
No.
Endoscope?
No. They should have the whole body CT scan. But if they go to the OR first and you have a doubt, because it's a very high velocity mechanism, you can anticipate the next step before going to the whole body CT scan by doing the transesophageal echocardiography and just activate the surgical team before going to the CT. But at the end of the first hemostasis surgery, you will go to the whole body CT before going to the OR because they will need the measures to operate the patient.
Yeah. Well,
Yes.
okay. There's a...
I just want to ask, would it be helpful to do EchoFast in a pre-hospital setting to anticipating the diagnosis, or it's better sort of time saving to rush in the emergency department and do the CT scan? Like, what is the best approach time-wise?
For this injury?
For this case, yeah. EchoFast in pre-hospital or not?
In the pre-hospital, you will find the source of bleeding. You will try to find the source of bleeding to anticipate what will be done in the hospital. So if you have, for example, hemoperitoneum, you can say the hospital team, get ready, because this patient is very, very severe in hemorrhagic shock and has a hemoperitoneum. But the fast echo won't help you to diagnose the aortic injury because it's very specific. I mean, it's a fluid in cavities to know which is the source of bleeding. So you won't have the answer. It just helps to activate the team by anticipation.
Okay, Sophie, we thank you.